Good morning, Dr. Griffith. I've just made you co-host.
Good morning.
Good morning.
How are
Are
you
you
today?
going to be, I'm doing fine. I'm your moderator.
Okay.
And do I need to give you a share screen?
Yeah, I
option?
have I have my slides ready, and so yeah, if so I should be able to share my screen when the time comes to so folks can see my slides. Is that that's how I usually do these things? Is that
All
going to
right,
work?
I've given you access.
Okay. All righty. Well, you just tell me. It looks like I have 9:26, so probably wait a few more minutes.
4 more minutes.
And you let me know when you want me to begin.
All righty. And will you be doing breakout sessions?
No, not that I know of.
Oh, thank goodness.
Yeah. I was told just a live presentation and then some times for questions.
All right.
How long is this one for? Is it for 1 hour?
It is 1 hour.
Okay. We should easily be able to do that.
Great. Thank you. People are still coming in.
Sure.
Good morning. How you doing? When I seen you yesterday, I wanted to say hi to you. This is Yvonne.
Good morning, Yvonne.
How you doing?
I'm doing well, thank you.
I can't wait till we get back in person.
I was just talking about you a couple of weeks ago.
Yeah, I'm still pushing out them interns.
Awesome.
Well, it's nice seeing you here.
Thank you.
You're welcome. Let me put me back on mute so I won't bother nobody.
Okay, thank you. We've got 2 more minutes.
I'm going to go ahead and get this up. Patty, can you see that?
I can.
Okay.
Full view, perfect.
Okay. Just close that and close that. Okay.
It is now 9:30 on Thursday, May 20th, oh, not May 25th, May 5th, and welcome to session E1. And Dr. James Griffith is the chairperson from West Virginia Department of Behavioral Medicine and Psychiatry. And he'll be our presenter for psychiatric consequences of COVID-19. Just want to make sure that everyone is muted during the presentation. If you've got any questions, go ahead and type them in the chat box. I'll be monitoring those chats because at the end of his presentation, we'll have a Q&A session. Also, make sure you include, type in your name in the chat box to verify your presence for this presentation. If you are using your phone, include your phone number with your name in the chat box. And again, let's have an incredible morning of presentations. It's all yours, Dr. Griffith.
Okay, yeah. Well, I don't know if it'll be incredible or not. I'll try. I'll do the best I can. Thank you, Patty. As Patty mentioned, my name's Jim Griffith. I am an internist and a geriatric psychiatrist, and I work at the Charleston Division of WVU School of Medicine and practice at CAMC. And I've spoken several times at this conference over the years, and I was very excited to be invited back. So I appreciate that invitation from the social work community. So I thought this might be a timely topic. And like someone else said earlier, I also look forward to when we can get back together and meet in person, because I enjoy that very much, and seeing colleagues and friends from around the state that have attended previous presentations that I've given. This will sort of be, I would say, kind of a two-part presentation. The first part will be devoted to some descriptions of clinical syndromes that are seen in patients who have had COVID, and some discussion of the pathophysiology, what's going on in the brains of these patients, and why are they developing these sorts of mental problems after COVID. And then the second part will be a brief summary of some of the what I would call more effects of COVID-19 on the psyche of the general population, and how that has played out and affected our practices, and how is it affecting the mental state of the community at large. So there's kind of two parts to this presentation. And Patty, again, if you kind of keep track of the chats for me and that sort of thing, that would be helpful. And I will try to save a little time at the end for some questions and chat responses and things like that.
Absolutely.
Thank you. So this is just simply an example of a news headline which sort of introduces the topic, and this is still very true. Experts are indeed alarmed by the number of COVID survivors who are not coming through COVID unscathed in terms of their mental and neurologic state. There is a large number of people who are suffering from chronic mental problems that are the residual of their COVID infection. A little bit of introduction about COVID-19, because I know there may be some folks here that are not necessarily medically trained per se. COVID-19, the name was coined by the World Health Association, where the CO stands for corona, and VI is virus, and D is disease. And the 19 refers to the year that the virus was first discovered, so 2019. So hence the name COVID-19. This virus and its consequences was officially declared a pandemic by the World Health Organization in March of 2020. COVID-19 is certainly not the only coronavirus that affects humans, and there are currently 7 types of coronaviruses which are known to infect humans, and most of them are produce the common cold. and are of little clinical consequence, and generally just produce runny nose, headache, cough, the usual things you would associate with a upper respiratory infection, and would rarely lead to something like a pneumonia. And coronaviruses, of course, are known to spread person to person, generally through coughing, sneezing, and hand-to-hand contact with people who are infected. So the coronaviruses have been around for a very, very long time, but most of them up until now have been relatively benign sorts of conditions. However, there are some other more serious coronaviruses from our past that have been of animal origin and have produced serious medical problems, although they were brief and contained rapidly. And the first of those was SARS, which was reported in Southeast Asia in 2003. And SARS stood for severe acute respiratory syndrome, and was clinically resembled COVID-19 in many respects, but it was not as contagious. And so consequently, it was contained quickly and did not spread around the world. And then in 2012, some of you may remember MERS, or Middle Eastern Respiratory Syndrome, also a coronavirus that was first reported in 2012 in Saudi Arabia. And there have been only 2 cases known in the United States in the last 10 years of MERS, and there hasn't been any cases reported for several years. So there have been prior coronavirus outbreaks that resulted in serious illness, though in a very limited number of people and a limited area of the world. Everybody knows, I think, or has read about the so-called spike protein of the COVID-19 virus, which allows it to attach to receptors on host cells, and that then facilitates entry of the virus into the cell where it begins reproducing. And then that results in a complex humoral and cell-mediated immune response, which we will talk about a little bit today, not in great detail, because a lot of the problems that we see with COVID are not so much with the virus itself, but with the body's response to the virus and the intense inflammation that occurs in a variety of body tissues. And of course, we're going to focus on the brain today primarily. Now, this doesn't project very well, and I apologize for that, but this diagram is intended to sort of summarize the important pathophysiologic pathways by which COVID causes brain damage. And there are 3 primary things I would like you to keep in mind that are going on in patients with severe COVID. And the first of those is the intense systemic inflammation, which we will talk about, and how that leads to damage to organs where that intense inflammation is taking place. And again, today we're going to focus on the brain as the primary organ. There is also a large amount of thrombosis, in other words, occlusion of blood vessels occurring in patients with COVID. And when this occurs in the central nervous system, then mental deficits and mental symptoms result. And then finally, when patients have moderate to severe COVID, they become hypoxic. And that results in tissue ischemia throughout the body if it is not rapidly corrected. So all 3 of those mechanisms are in play in patients who have COVID. So intense inflammation resulting from the viral infection, thrombosis of blood vessels in many areas of the body, including the brain, and tissue ischemia from hypoxemia created by the infection. So all those things will contribute to brain damage in patients who have COVID. So I'll talk a little bit about some of the more widely quoted studies that have investigated this. This is an Italian study of 108 COVID patients with neurologic symptoms. And you can see that thrombosis and stroke is a common problem among these patients, with up to a third of them having an acute stroke associated with their illness. A central venous thrombosis, which is basically a thrombosis of the blood vessels which drain the brain of their blood supply. Intracranial hemorrhage is not rare in patients with COVID-19. And then also a sort of non-specific encephalopathies and posterior reversible encephalopathy, which are non-specific encephalopathies found in patients with COVID-19. So a large number of patients having neurologic problems. Talk a little bit about thrombosis in COVID-19. Why does this happen? The primary reason it happens is that the vascular lining of the blood vessels expresses a receptor which is enticing to the COVID-19 virus. And the virus binds to this receptor in the blood vessel lining and then produces an infection in the vascular endothelium and extensive inflammation in the perivascular area of these blood vessels. And that leads to thrombosis of these blood vessels. And frequently this occurs in the brain. So there's very good reasons pathologically why COVID likes blood vessels, because the particular receptor that the virus binds to is quite prevalent in the lining of cells in our blood vessels. As mentioned earlier, there's a lot of tissue ischemia or lack of oxygen to tissues in patients with COVID-19. This can be a result of extreme hypoxemia from severe lung infection. And then also patients with COVID-19 often develops a shock-like syndrome with hypotension. And then you combine that with thrombosis and vascular inflammation and you get cerebral ischemia. Now, you also get it in other organs as well, but we are focused today on the brain. And then inflammation. And this has been studied a lot, and I'm not going to get too bogged down in the details, but there are consistently very high levels, extremely high levels of inflammatory markers, including what are called interleukins and granulocyte stimulating factor and so forth in patients with COVID-19. And one particular interleukin which is focused upon is IL-6, which is known to activate coagulation in our bodies when the levels of IL-6 are high. IL-6 is also associated with multi-organ failure and other infections. And so IL-6 has been a key target of treatment efforts in patients with COVID-19, including tolicizumab, which is a monoclonal IL-6 antibody that is designed to neutralize IL-6, and it is approved, or at least recommended, as an option for patients with severe COVID-19. But the combination, again, I want to reemphasize, of inflammation, ischemia, and thrombosis are what's happening in the brains of patients with COVID-19. So what does that result in? Okay, so we see a variety of neurologic and mental problems in patients with acute COVID-19 syndromes. Delirium and psychosis is very common in these patients. As I mentioned earlier, both thrombotic and hemorrhagic strokes are also common in patients with COVID-19. Encephalitis per se is relatively rare, and because the virus does not really have a predilection to necessarily infect neural tissue per se. It infects the blood vessels, not so much the brain tissue itself. There are several reports also of Guillain-Barré syndrome, which is an ascending paralysis syndrome affecting the peripheral nervous system. And then, of course, the well-known symptoms of loss of smell and loss of taste are also neurologic symptoms seen in COVID-19, and is a result of these processes in the areas of the brain that control smell and taste. So even those symptoms are included in neurologic aspects of COVID-19. Rarely we will see seizures and other presentations, but the more common ones are confusion, delirium, psychosis, loss of taste, loss of smell, and stroke in the acute setting. Those are what we see most frequently. So a little bit about the delirium and psychosis. This is seen in up to 2/3 of patients who are hospitalized with COVID. So it's very, very prevalent in patients who are hospitalized with COVID, and particularly if you are sick enough to require the ICU, and also if you have pre-existing dementia before you develop your COVID infection. Confusion can be the presenting symptom of COVID without much else. And particularly in elderly patients. And these patients often have extreme rigidity and stiffness of their muscles and are often mute as part of their presentation. This is somewhat specific for COVID. This is not seen very frequently in other forms of hospital-associated delirium. I won't go into the management of this too much, except to say there's not a lot of data on how to manage these patients. Most experts are advising to avoid products like Risperdal and Haldol to manage these delirious patients. These are drugs we often prescribe to patients with delirium in the hospital, mostly because they make the muscle stiffness worse. And so there is a soft recommendation to utilize drugs with less propensity to do that, such as aripiprazole or olanzapine. VPA is valproic acid or trazodone, and then perhaps lorazepam, which is Ativan. But all of this is very preliminary, mostly based on expert opinion. There haven't been any trials comparing various regimens to treat delirium associated with COVID-19. But these are current recommendations from experts in the field about medicines that would be reasonable to try, that are pretty safe, and ones that you should probably avoid. Stroke in COVID-19 patients occurs in up to 5% of hospitalized COVID patients, and mostly these are acute ischemic strokes, but intracerebral hemorrhages are also not uncommon. And unfortunately, we're seeing a fair amount of these in younger patients with COVID who have no vascular risk factors. So typically, if you have a stroke, usually these are people that are older, that have vascular disease elsewhere. They might have atrial fibrillation or something like that. That's not what we're seeing in COVID-19 patients. These are young patients, relatively free of cardiovascular risk factors, who are developing large strokes as part of their COVID-19 illness. And some of these have been rather tragic, actually. And at least from a large study in Japan, if you had a stroke associated with your COVID-19, that was a very bad prognostic sign, and up to 44% mortality in patients with stroke as part of their COVID-19 illness. Again, as I mentioned earlier, why are we seeing so many strokes in patients with COVID-19? And it has to do with the inflammation, the resulting hypercoagulability, and disruption of the vascular lining in our blood vessels supplying the brain, as also hypotension and hypoxemia probably plays a role. The management of stroke in COVID-19 is not much different than the management of other strokes, although experts have been reluctant to administer strong anticoagulants and to patients with COVID-19 because we see more hemorrhagic conversion in these patients. So again, the typical management is relatively conservative and directed towards rehabilitation and so forth in patients who have strokes associated with COVID-19. I don't know how well any of these images will project. This is an example of a patient who had COVID-19, and the arrows point to multiple areas of infarction or stroke in this patient's brain. And this person previously had no history of a stroke, no history of brain problems. And you can see that there is widespread infarcts, both sides of the brain, affecting this patient as seen on their MRI. And they are designated by these arrows on this MRI scan. Encephalitis does not occur very often with COVID-19, as I mentioned earlier. The encephalitis means a direct infection of the brain tissue by the virus. It can occur rarely. The typical presentation is fever, headache, and altered mental status, but this is not seen very frequently, and the usual treatment is simply to administer medicines for severe COVID. This is, again, I do not know if this will project well, and particularly if you're watching on your phone, but again, the red arrows depict areas of brain necrosis in a patient with COVID-19 who developed encephalitis. So there's widespread areas of necrosis on this MRI, and this patient had a severe case of encephalitis associated with their COVID-19 infection. Another presentation rarely seen, this is diffuse ischemic damage pointed out by the arrows. So this patient has widespread ischemic damage, both cerebral hemispheres, in the occipital lobes as well as the parietal lobes. This patient is in bad shape and has severe brain damage as part of of COVID-19. Guillain-Barré syndrome is an uncommon ascending paralysis. It has also been, Guillain-Barré syndrome, as you probably know, has also been rarely reported following COVID-19 vaccination. But it is also can be associated with the COVID-19 illness as well, and it is generally treated with intravenous gamma globulin or plasmapheresis. So those are sort of the things you see in the hospital acutely. Now I want to move on and talk a little bit about what happens to people after they've recovered, so to speak, from the acute illness of COVID-19, because we are seeing a lot of chronic and subacute mental problems in these patients. And most commonly what's been reported are depression, anxiety, post-traumatic stress disorder presentations, cognitive impairment, or what has been loosely referred to as brain fog, and sleep problems in patients who have again, recovered from the acute aspects of their COVID-19 illness. This is a fairly widely cited study from Italy that looked at and followed more than 400 patients who had been hospitalized for COVID-19 and then were screened 1 month after discharge. And you can see relatively high rates of psychiatric problems in these patients, with more than half reporting at least one of the symptoms I mentioned, either depression, PTSD, anxiety, or insomnia, or some combination thereof. So more than half of our patients who were discharging from the hospital with COVID-19 a month later still having significant psychiatric problems. Again, the potential, why does this happen? Again, inflammation, maybe blood-brain barrier disruptions, maybe HPA axis dysfunction, which has to do with the pituitary adrenal gland dysfunction following COVID-19, and other inflammatory activity in the brain, and also residual effects of undetected microscopic thrombosis is also probably another contributing factor to these persistent mental symptoms. There's also obviously a physiologic contributing factors to this. There is a lot of, shall we say, psychosocial aspects to having COVID-19 and how it affects your life. And this sort of goes without saying, and you guys have lived all of this, but patients who have COVID-19, at least early on when they were hospitalized, visitors were not permitted. They had to sort of endure this with just the help of the staff in the hospital and perhaps telephone contact with family members. So there was a lot of social isolation during the hospital stay, and then even further social isolation when they were home for fear of spreading the illness. There was COVID-19 patients have a lot of anxiety about infecting other people, particularly if they share their home with someone who's elderly, or they share their home with someone who is immunocompromised in some way or has risk factors for poor outcomes. Then patients become very anxious about that as well. And as in most cases, if you did have a history of mental illness before you developed COVID, that does increase your risk of having further mental illness problems after COVID as well. There's not a lot of data about how to manage these patients that are presenting with depression or anxiety after they've had COVID. There's a few small studies looking at simply relaxation techniques, supportive counseling, yoga. All of these have found to be somewhat beneficial in small groups of COVID survivors. Most experts like the idea of administering SSRIs to these patients because SSRIs do have some mild anti-inflammatory properties. And interestingly enough, the third medicine listed here, fluvoxamine, which is Luvox, has actually been studied as a treatment for COVID-19 and with some mildly favorable results. So most folks do recommend probably starting with an SSRI if you're going to prescribe medication to patients with depression and anxiety who are COVID survivors. Benzos or tranquilizers such as Valium, Ativan, Xanax, and so forth are not recommended, primarily because they have deleterious cognitive effects, and many of these patients already have some cognitive difficulties as part of their presentation. So most experts are advising trying to avoid prescribing benzodiazepines to these patients. Talk a little bit about so-called brain fog, or what is referred to as neurocognitive dysfunction in patients who have had COVID-19. This is characterized by impairments in memory, concentration, attention span, and mental processing speed. It's also been referred to as dysexecutive syndrome. And this problem was previously reported in patients who survived MERS and SARS 10 and 20 years ago, respectively. So this is known to be a problem with serious coronavirus infections from the past. It's just that now we have millions and millions of patients who have had COVID, and so we're seeing many more patients now with brain fog following COVID-19. Most experts believe, again, it is a result of inflammation in the brain, perhaps brain hypoxemia that occurred during the acute COVID illness, and likely microscopic cerebral thrombosis causing brain damage in patients with these sorts of presentations of what we just refer to loosely as brain fog following COVID-19. Not a lot of information about treatment of these patients. There really aren't any recommendations for clear pharmacologic treatments. There's a few little tidbits out there, but mostly this is the World Health Organization's current recommendations for patients who have brain fog is one, adjusting expectations of the patient. That means you just basically have to wait it out. There are some soft indications that mental exercises can be beneficial. And then making lists and reminders to help with people with memory problems and trying to simplify tasks and do things a step at a time and those sorts of things. So these, again, this is, I would characterize largely as sort of a supportive type of approach to patients with brain fog, trying to educate them about, yeah, this is a consequence of your COVID-19. There is some evidence that it does get better with time, but that the long-term outcome of these patients remains to be seen. There are some case reports of using products like donepezil, which is Aricept, and memantine, which is Namenda. These are products, as you know, probably, that are approved for the treatment of Alzheimer's dementia. Also some case reports of using famotidine, which is Pepcid, which is typically prescribed for reflux and acid problems in the stomach, but has been found to have some activity against the virus, and the same thing with fluvoxamine, which is Luvox. But I can't really firmly recommend any of these pharmacologic treatments for these patients. There's just not enough evidence to do that. But there are some isolated reports in the literature of people trying these things to try to help patients with brain fog after their COVID-19 infection. So to summarize this portion of what I wanted to talk about today, persistent neurologic psychiatric symptoms are very common in COVID-19 survivors. Probably up to half will have some sort of psychiatric problem in the months following their COVID-19 illness. That can be depression, it can be anxiety, it can be sleep problems, it can be brain fog. All of these things are quite common after COVID-19. We believe they are a result of inflammation, hypoxemia, and hypercoagulability in the brain. If you have to manage a psychotic or delirious COVID-19 patients, there are advice to use low potency neuroleptics and avoid haloperidol and risperidol, but treatment for the long-term problems are not yet clear for these patients. So before I go, maybe I'll stop here, Patty, and just for a minute, and before we go on and talk about this part of which is mental health of general population during COVID-19 pandemic, and I'll see if folks have questions at this point about the kind of basic pathophysiology and individual patient presentations.
There were a couple of questions earlier, but it seems like you answered them. But maybe you could elaborate on Dolores's question about how long does brain fog last? You did say that it's the long-term effects is yet to be seen. Could you elaborate?
Yeah, there is a little evidence that it can slowly improve from the reports I've read over a period of several months. But there are patients that, at least have not fully recovered their cognitive function up to a year after their COVID-19 infection. Now, what will happen to them, 2 years from now, 3 years, we don't know, obviously. I would tell you, if it's like previous sorts of conditions, the usual interval that we advise, if they've had some sort of brain insult, like a brain injury or a stroke or something like that, we'll usually tell patients that you can expect some improvement for up to 2 years. And then if after 2 years you still have residual symptoms, those are likely to be permanent. But so I don't know if that applies to COVID-19 brain fog or not. But I think what I would say is to try to encourage patients to say that we expect to see probably some slow, gradual improvement over a period of 6 to 24 months if it's like previous brain insults that we've dealt with from other causes. But that's the best guess I could give you.
Thank you. Jessica also asked, are these conditions also present in mild cases of COVID-19?
Yes, they are. They're not as prevalent. So the percentage of patients who develop things like depression, anxiety, insomnia, brain fog is lower in patients who had mild cases, but it is not zero. So yes, but the likelihood that you develop a brain problem after COVID-19 is related to the seriousness of your case. So the sicker you are, if you end up on a ventilator, if you end up in the ICU, you're much more likely to have these problems. But lower percentages of patients who have mild cases of COVID have all these same problems. They're just not quite as prevalent as those who were hospitalized or are in the ICU or on ventilators and so forth. So absolutely, they occur in patients with milder cases of COVID-19. Yes.
Right. Kara asked, any evidence that the vaccine has any impact on long-term COVID?
Yes. There is evidence that long COVID symptoms like brain fog and fatigue are seen less frequently in patients who've been vaccinated and then develop COVID. So yes, there is evidence that the vaccines reduce the chance of developing long COVID, so to speak. All of these things I'm talking about do fall into the rubric of long COVID, but I'm focusing on the mental and psychiatric aspects and not so much things like myalgias and fatigue and joint pain and that sort of thing, which are also part of it. But yes, the vaccine does reduce the chance. Doesn't make it zero, but it does reduce the chance that if you get COVID, you would suffer long COVID symptoms.
Megan said, I will be interested in seeing future studies on the effects of COVID, both for severe cases and mild and moderate.
Yeah,
and then Carolyn, sorry, go ahead.
Yeah, there's an absolute ton of research going on and looking at those. So yeah, there's just an avalanche of information. It's actually sort of hard to sift through and keep up with. There'll be more information coming.
All right, Carolyn, I'm not sure I'm reading your post correct, so you can go ahead and unmute yourself because she asked, could it have triggered schizoaffective disorder?
Schizoaffective disorder. Yeah, well, it can certainly produce psychosis. There's no question about that. And actually, there are patients who have
or at least schizophrenic type symptoms, at least.
Absolutely, yes. So it could certainly evolve into an illness that resembles that. Yes, that has been reported.
That's good to know. I had a client, I'm not sure if he was diagnosed previously with that or not, but he all of a sudden has become schizoaffective.
Following a COVID case.
Well, he was sick, but I don't know if it was officially COVID or not. Is the only problem. I'm gonna have to double check with his nurse, but that is something I want to look into now that I have more knowledge.
Yeah, it's hard to know, whether that's a coincidence or not. That's difficult to know.
Thank you, Carolyn.
It's strange presentation at his age. So thank you.
Thank you. Brandy shared that her husband continues to have brain fog and they're going through into the 5th month, 5 months.
I'm sorry to hear that. Yeah, that's not that would be completely consistent with what's in the literature, that patients will have brain fog for many months after their illness.
All right, we got another question. Certainly a concern that there There is no long-term study yet. Are there studies that the psychosis and other forms are related to vaccine or COVID itself? Very scary.
There aren't any reports of psychosis due to the vaccine that I'm aware of. I'd have to double check that to make sure there. And but yeah, the whole thing is very frightening. Exactly, that that a viral illness could produce persistent brain damage. Yeah, the whole thing is it is very. And I would also say, of course, as mentioned by the folks, are very frustrating, for the clients. Because I'm not sure the general population necessarily sort of appreciates how common this is. And I think some of the clients may face some obstacles in that regard in terms of trying to seek help. So I think that I think that is a scary problem for our patients.
Thank you. Carla said, my daughter-in-law 2 years ago tested positive for COVID, and the only symptom she had was taste issues, and this continues. Is this common?
Yes. The loss of smell and loss of taste can be, I don't want to use the word permanent because we're kind of still, early into this. But there are many other patients who have, but at least loss of taste and smell that hasn't come back yet. Now, again, I don't know if I want to use the word permanent yet, because most of those folks have only had it for maybe a year or two, but that feels permanent to me when somebody has a neurologic symptom that's lasted for 18 months and it hasn't changed. But we'll see. Whether 5 years from now maybe it'll be better. But yes, there are plenty of patients who have had persistent loss of taste and smell following a COVID bout.
All right. Jessica wrote, I did research for writing a grant proposal, and I found that there was an increase for at risk of psychosis during the past 2 years.
Yeah, we're going to get to that. Yep, that's coming up. Yep.
Okay.
Yeah.
Dolores said, is this COVID-19 related to animal origin?
That's controversial. And not everybody agrees. And so I don't know if we'll ever conclusively know the origin of this particular virus. There are some who believe it originated in China in bats. However, there are others who believe that it was produced by humans in a laboratory. And so I sort of hesitate to wade in on that controversy. But there is support for both theories. So I don't know if we'll ever know for sure the exact origin of this virus.
All right. Nicole wrote, I had a kiddo I worked with who ended up with acute, how do you pronounce that word? Encephalitis?
Encephalitis.
And was having severe changes in her behavior. Myself and the provider felt initially it was just behavioral, as she appeared to be in control of her actions at times. However, upon her mother's urgency, she was taken to Children's in Pittsburgh. After many tests, they finally found out that she had this. They didn't anticipate this, as she was not very sick.
Yeah, again, and that's certainly reported. I don't see children, so I'm not an expert in pediatric stuff, but yeah, there are reports of serious mental consequences from patients with relatively mild cases of COVID. And it sounds like that's what happened to that child. And, again, the difficulty is, well, what do you do? And it's hard to know. And because typically you end up still treating sort of the target behaviors with medication or perhaps counseling in a case like that. But yes, that sounds tragic actually, but yes, that can happen. And it does happen in adults as well.
All right.
All right, so
We're
good.
good.
The last part will be fairly quick because I want to shift gears a little bit and talk about the mental health changes that have occurred in the general population during the COVID-19 pandemic. And as I tried to prepare this, it was very challenging actually for me, because I was not prepared for the sheer volume of information that's out there. There are literally hundreds of published studies from all over the world looking at this and trying to figure out what's going on in the general population during the pandemic. And the results are somewhat variable. So I tried to coalesce it and summarize it as best as I could. So this will be sort of a broad general overview of all that information that I could get to. Generally speaking, most surveys of the general population have found that during the COVID-19 pandemic, most people report increased rates of stress, variably defined, increased rates of anxiety and depression, increased rates of sleep disturbances, increased use of tobacco, alcohol, and illicit drugs, reduced rates of exercise and physical activity. And in general, these problems of anxiety, depression, sleep disturbance, drug and alcohol use, and tobacco use were found to be more commonly increased in young people compared to older people. So the thinking there is that particularly for our younger folks, this has been a very, very difficult time. And I think that would be consistent with my observations just based on what I see coming into the ER and into our practice. This has been a very difficult time on teenagers and young adults, the pandemic. And maybe us older folks are weathering it a little better because if I don't go out somewhere, I'm perfectly happy to stay home. Whereas younger people are not like that and have a lot more problems with the results of the pandemic and not being able to socialize and go to school and so forth. Healthcare workers have been studied a fair amount. There's been a lot in the paper about healthcare workers and how our healthcare workers, and a lot of you on this presentation would be considered healthcare workers. And how are we doing during the pandemic? And the answer is not too well. Healthcare workers report a lot of stress related to the fact that a lot of anxiety and fear because they're frequently exposed to COVID patients in the course of their work. They're very scared about bringing it home to their kids or bringing it home to their family or friends. So there's a lot of anxiety among healthcare workers about not only getting exposed at work, but then bringing the illness home. As everybody knows, there's been the Great Resignation across the country in all kinds of fields. It has hit healthcare really, really hard. And there is a lot of retirements, a lot of resignations, a lot of folks saying that this is, I didn't need much of an excuse to leave, and this is it. And they have left. And so for the ones who are remaining and still working in the nursing homes and hospitals and ERs and clinics, they've been working more to try to compensate for that. And that increases their stress. And so among healthcare workers, increasing rates of anxiety, depression, and sleep problems, not unexpectedly, have been reported. As I mentioned earlier, children and adolescents have had a very difficult time during the pandemic. And there are a lot of contributing factors. I've just listed a few of them that most folks think are relevant. School closures, inability to participate in athletic teams, inability to participate in clubs and extracurricular activities, cheerleading, you name it, social clubs, civic clubs, all those things were canceled for the last few years. And then for those who already had pre-existing mental illness, so they might have had already problems with depression or anxiety or conduct problems, and also those with neurodevelopmental disorders like autism and autism spectrum disorders, those children have been particularly adversely affected, and we're seeing increased rates of psychiatric problems in those patients during the pandemic as well. So in children and adolescents, increased rates of depression have been reported. Interestingly enough, some of the studies show some mixed results in rates of anxiety. And the thinking here is that those children who are already anxious actually reported a reduction in their anxiety during the pandemic because they were allowed to stay home, which they were more comfortable staying home and not having to be forced to socialize and interact in a school environment or a classroom environment. So you actually saw some reduction in anxiety in children and adolescents who had already social anxiety and problems like that. Unfortunately, we have seen in children and adolescents increased rates of suicidal ideation and also increased rates of non-suicidal self-injury and we're seeing this in our ERs. With more children and adolescents coming in with suicidality and following either suicide attempt or parasuicidal behavior. The rates of all that is increasing and has been well described in the literature. Lots of children coming in with these types of crises. More problems with ADHD is reported. Children with ADHD have seem to have a lot of difficulty with some of the virtual learning types of formats, and then also sleep problems. And interestingly enough, those with eating disorders are also reporting increased problems with eating disorder symptoms, which is usually a stress response. So all of these things have been reported in surveys of children and adolescents around the world and in the United States during the COVID-19 pandemic. Some of the surveys, interestingly, did report a few positive things that children and adolescents reported as a result of the pandemic. It was encouraging to see this, that some children and adolescents reported that it was a positive thing because they got to spend more time with their parents and their siblings and actually built a better relationship with their families as a result of sort of spending more time together. So I thought that was an interesting positive response that was found in some of the surveys. They reported improving communication with their parents, which was a positive thing. And of course, they also liked the fact they had more playtime, and relaxation time because they weren't going to school. So there were some positive things that young people reported during the pandemic. So in summary, what we're seeing and that's been reported is increased rates of depression, increased rates of tobacco, alcohol, and drug use, increased rates of suicidality and parasuicidal behavior in young people, lots of sleep problems, and less physical activity. Again, all the gyms were closed and all that sort of thing, and so much less physical exercise. And I'd be interested to know if these reported changes, sort of align with what you guys have seen in your own practices, if you're involved in psychiatric settings. This has been fairly consistent with what we've been seeing. I think that's Patty. I think, yeah. Oh, well, there's a picture. Okay. The COVID-19 virus in full color. So
Dr. Griffith.
Patty, are there some questions or comments from in the chat?
Yeah, we have one where someone said that there's a significant higher number of children and adolescents coming into the behavioral health center. And let's see, the Bureau of Behavioral Health has a first episode psychosis program, and this is from Jessica, and she provided a link.
Nice. Okay.
Yeah. Another person said that they've seen an increase in ADHD and anxiety symptoms in school-aged children.
Right. Yep. Yep.
Lots of affirmation about how incredible your presentation has been in terms of being informative. We had one from Elizabeth. She said she had COVID in 2020 and now has asthma and didn't have it before.
Right. Yeah, that was not my focus today, but that is absolutely. I can tell you that asthma developing after COVID is well reported. That's a known consequence of COVID. There are there's cardiac effects. There are renal problems. There are peripheral nervous problems. There are muscle problems. There are joint problems. But my focus today was on mental and neurologic problems. But yes, many other organs systems can be have chronic consequences from COVID. That is correct.
Dr. Griffith, you have homework to do. Some of the participants wanted this presentation to be a little bit longer because it was very informative.
Okay, I'll add to it, for the next, and maybe by next year we'll have some new information about maybe how to treat some of these folks, hopefully.
Well, thank you again, and thank you to all the participants for being in this session.
I hope it helped. I hope it was informative. I hope people enjoyed it. It's hard to know on these Zoom calls, but I appreciate you inviting me, and I look forward to perhaps presenting again if you'd like next year.
Awesome. Our next presentation session begins at 11 o'clock. So you all take care. Bye now.
Patty?
Yes. Who's talking to me?
Is there some way you can copy that chat to send to Dr. Griffith? Or maybe I can. I don't know how to do it though.
Let me see if I can do it.
There's a question about the slides, and I sent the slides to Molly.
Thank you.
So Molly has the slides, and I don't care who she sends them to. So
that's great. That's great. And Griff, did you get a chance to see the chat and all the appreciation?
Oh, okay. Thank you, Betsy.
Please look at it. It's pretty wonderful.
Okay. Well, I enjoyed it. Thank you so much for having me, Betsy. Okay.
Oh, thank you for doing this.
Again, so Patty, Molly has my slides.
Okay. Yes. And it should be posted, and I provided the link. Thank you so much.
Okay.
I'm going to see if I can copy.
Yeah. Okay. That's
the chat.
That's it. Okay.
I see you nodding. Does that mean you got it?
It's still going. I'm still trying to copy everything.
It's a lot, yeah.
It is.
There were
is
over
a
200
lot.
people in the session. It's almost like a mini keynote.
Shucks. I am not getting it. I don't know what I'm doing. I just lost it. Let me try again.
Do you want me to see if I can get Brian to do it?
Yes, please.
Okay.
Let's go. Keep going.